Good afternoon, everyone. My name is Soo-hyun, and I'll be presenting my retrospective observational study on serial sky reassessment and the use of mechanical circulatory support in STEMI-induced cardiogenic shock patients. This project was conducted under the guidance of Professor John French and Professor Rebecca Dignan. Cardiogenic shock is a life-threatening state of systemic hypoperfusion caused primarily by cardiac dysfunction. It complicates around 5 to 10% of ST elevation myocardial infarctions called STEMI and has a high 40 to 50% mortality rate. Mechanical circulatory support devices are widely used interventions that provide hemodynamic support in these patients. While their evidence of survival benefit is conflicting, most studies have not accounted for the severity of cardiogenic shock among patients in unmatched groups. To address this, the Society of Cardiovascular Angiography and Interventions introduced the SKY shock classification, which stratifies cardiogenic shock from class A to E with increasing severity. Nevertheless, current studies on SKY classification and mechanical support includes a mixed cohort of cardiogenic shock patients induced from varying causes demonstrated in the following figure. Consequently, they fail to address the unique impacts of mechanical support, the prognostic value of the initial SKY classification, and the change of SKY classification in STEMI-induced cardiogenic shock patients. To address these gaps, our study aimed to assess the prognostic impact of the change in SKY class over the first 24 hours and of mechanical support in the survival of STEMI-induced cardiogenic shock at 30 days, 1 year, and 5 years. In our retrospective observational study, we began with extracting patients from angiogram records between 2006 and 2021 with angiographic indications of acute myocardial infarction or cardiogenic shock. Then, we confirmed the diagnosis of STEMI and cardiogenic shock through a combination of clinical symptoms, biochemical markers, and specific ECG criteria. Lastly, we classified patients into SKY shock stages at diagnosis and 24 hours later. For analysis, we used Kaplan-Meier survival curves and multivariate Cox regression to identify variables associated with survival. I'd like to take a moment to acknowledge the contributions of Angus Lung, the previous year's honor student who adjudicated 160 STEMI cardiogenic shock patients for his research study and passed down the foundational data set containing key data of patients shown in Figure 4. Our findings on 306 STEMI cardiogenic shock patients were the following. First, in our forward multivariate model, the improvement in SKY class, defined as a reduction in SKY stage at 24 hours compared to the initial diagnosis, was significantly associated with improved survival outcomes, and patients experienced an 80% reduction in mortality risk at 30 days. The Kaplan-Meier survival curves for each SKY class show significant differences at survival at 30 days, 1 year, and 5 years, with most deaths occurring in the first 30 days. Lastly, the survival curves for the combined group of patients classified as SKY C, D, or E, stratified by the use of mechanical support, show significant differences in survival at all time points and a lower survival rate in patients treated with mechanical support. Now, let's explore their clinical implications. Our findings on the improvement in SKY class at 24 hours emphasizes the importance of frequent reassessment, especially during the first 24 hours of cardiogenic shock. It also highlights the dynamic nature of cardiogenic shock, where early and continuous assessment of severity is crucial to guide timely and effective treatment. Additionally, the survival curve for each SKY class align with existing studies validating SKY classification as a reliable severity scale for cardiogenic shock. However, interestingly, the survival curves for the patients in the combined SKY C to E group showed that those treated with mechanical support had lower survival rates, deviating from the result of current studies that show similar survival curves between the two groups. This may reflect a higher baseline risk in these patients and raises questions about the variability within each SKY class and suggests that even patients classified in the same stages can have significantly different clinical status. Before concluding, I'll address some limitations. As a retrospective study relying on historical medical records, missing data, particularly the lactate, with 25% of patients missing this data at any time point, posed a challenge in accurately assessing shock severity and may have introduced researcher bias during classification by relying on less reliable indicators. Furthermore, 97.3% of STEMI CS patients treated with mechanical support received IBP, an older device contested benefit. Given newer technologies like microaxial flow pumps showing improved survival in recent studies, our findings may be limited by reliance on older mechanical support devices. In conclusion, our study found that early improvement in SCAI classification is a variable strongly associated with survival in STEMI-induced cardiogenic shock, emphasizing the need for frequent reassessment during the first 24 hours. Furthermore, the lower survival rates in mechanical support-treated patients in SCAI C2E supports the current evidence towards no survival benefit of mechanical support. Future studies should focus on assessing the optimal time interval of SCAI class reassessment within the first 24 hours, as well as further stratification of the SCAI classification criteria based on patients' baseline characteristics to promote personalized risk assessment and treatment strategies. Thank you so much for listening. Any questions?